Hello, my name is Martha Coda, and for my Sports Medicine 3 Unit 4 Post-Surgery Rehab project, I'll be investigating meniscal root tears. The meniscus is the articular cartilage in the knee cushion between the tibia and femur. It prevents the two bones from rubbing against each other, and these serve as shock absorbers when movement is performed. Meniscal root tears typically occur when there's a twisting or torsion when the foot is planted, and meniscal tears occur when the root attachment of the meniscus is torn or detached. There's radial tears, which make up 90% of meniscal root tears, and radial tears are when the meniscus is torn 1 centimeter away from the root, but the root is undamaged, and the injuries seen more among the younger demographic and are usually accompanied by torn ACLs and some other injuries to the cruciate or collateral ligaments. Also, I'd like to mention that usually for this type of injury, we'd use a meniscal repair opposed to meniscectomy, just because a meniscectomy has some greater risks. They have a larger risk of osteoarthritis as well as re-injury, and since this is usually seen among a younger demographic, we really want to limit the amount of osteoarthritis being progressed, since if it progresses enough, they'll have to get a total knee replacement every 20 years, which would cause a very big strain on. Now, some signs and symptoms. Some common signs and symptoms is pain over the joint line, locking and catching, which is rare, popping, pain with knee flexion, and a positive McMurray's test. I'd also like to mention that when the foot is put in varus force, the meniscus will be extruded, and once the foot is back into its original anatomical position, the meniscal extrusion will disappear, and this is a very common sign of a meniscal root tear. And then this is a surgery video of a meniscal root tear repair. We can see that meniscus is kind of detached. When there's impact between the femur and the tibia from movement, it's causing that meniscus to move side to side opposed to just absorbing the movement, and it's wearing down on that bone underneath the meniscus, and eventually all of it will wear down, causing the tibia and the femur to rub right against each other, and that's going to cause osteoarthritis. The recovery timeline. So phase 1 is maximum protection, and that's week 0 to 6. Phase 2 is progressive stretching and early strengthening, which is week 6 to 8. Phase 3 is advanced strengthening and proprioception, which is week 8 to 12. Phase 4 is strengthening and plyometrics, which is week 12 to 20. And phase 5 is return to play, which is 20 and 32. And during phase 1, we really want to protect and limit the amount of force being put on the knee, especially since it's at a big risk of re-injury, being right out of surgery. And also the protocols during all these exercises is non-weight bearing crutches, no range of motion until 2 weeks, and then the brace should be locked at 10 degrees, and the main goal is patellar mobility. Week 0 to 2, we want to do passive knee extension and passive knee flexion at 90 degrees, and we can accomplish this with the use of a chair. And then we also want to do quad setting, focus on VMO contraction, open kinetic chain straight leg raises, and which is multi-plane, and then gait training with the use of crutches. And then during week 2 to 6, we want to do open and closed resisted hip strengthening, some proprioception, and we also want to make sure there's no weight bearing with that proprioception, especially since that's one of our main protocols. And then we want to start on a pool program, and it has been proven that running on water reduces the chance of overuse injuries, which is crucial during this phase of protection. Now, during phase 2, during week 6 to 8, we want to gradually work towards that full range of motion. This can start off as assisted range of motion or passive range of motion, how we had shown previously in phase 1. And during this time, we'll really work on those ABCs, on inversion, eversion, and then plantar flexion, dorsiflexion to regain those rudimentary biomechanics. And then we want to do lower extremity stretching program to warm up those muscles, and then a stationary bike, elliptical, and treadmill to start working. And then we want to do closed chain strengthening, and then some protocols as you want to gradually start weaning off of those crutches. And unless that athlete is 100% comfortable being without the crutches and there is no limp, then the athlete is welcome to stay on the crutches until they feel more confident and their posture improves. And we also want to open the brace, so the physician might remove their brace during this time. Now, during phase 3, which is advanced strengthening and proprioception, during week 8 to 10, we're really going to work on regaining all of that range of motion, and we'll continue working on phase 2 range of motion, which is inversion, eversion, since those are very primary movements. We'll add resistance to those to build up the strength and comfortability of those exercises. And then we'll do some gait training without the crutches, because during this time we'll completely wane off of those crutches. And we really want to keep in mind if the athlete is still comfortable or if their posture is good with no antalgic gait. And during this time, the athlete will most likely be off of those crutches compared to phase 2, which would have been a little earlier. And then during week 10 to 12, we'll do some strengthening to build up that muscle and reduce that atrophy. And then another protocol is that we want to avoid load bearing for 3 months. Now, phase 4 is strengthening and plyometrics. And one of the considerations is that the athlete will be using a functional brace during this phase. And from week 12 to 16, we're going to work on full strengthening program, and we'll do a full strengthening program and an advanced proprioception drill. And for this time, we can do some 2-legged exercises and then move them to 1 leg. And then just to build up that difficulty, we can use an AirX pad or we can use a Bosu ball. And we can start off with 2 legs, and then once you're more comfortable, we can move on to 1. But since we're still kind of working on that proprioception, we really want to make sure we know what's comfortable for the athlete, so it's better to start off with easier and work towards the more difficult, opposed to doing the most difficult and working to the easier ones. And then during week 16 to 20, we'll progress to running on land, and then low impact plyometric drills, which would be some lunges and some squats. And then during phase 5, it's return to play. And some considerations is that the athlete will have their 6-month examination with their physician as a follow-up. And then week 20 to 24, there'll be sprints. And during this time, you'll limit those sprints to short distances and make them longer progressively, instead of making them do one of the most difficult sprints in the early, just to build up that endurance. And then we'll have some field and agility drills with the brace on, and this will encompass any of the primary movements of their desired sport. For my program, I'm leaning more towards football, so we see more of the football field and some agility ladders, as well as some sprints across the field and some zigzags to really improve that change in direction and work on impact and plyometrics and explosive movements. And then during week 24 to 32, and these are the websites I visited to help me complete my presentation, it will be the return to play sports test. Thank you for listening to my presentation.